Well, hello, hi. This is Dr. John McAllister. I'm a dentist in Downey, California, and today I'm going to be talking to you about LAPIP. LAPIP is a protocol that's used to reverse gum disease that has happened around dental implants. Dental implants do get infected and they end up with peri-implantitis or peri-mucositis. So LAPIP is an acronym for laser assisted peri-implantitis procedure. It's done with a laser, the Nd:YAG laser, the perio laser. This presentation is brought to you by the number 22. 22, without 22, we would not be able to place implants at this time. What I'm talking about is the number 22 inside the periodic table, titanium. Most dental implants are made of titanium. When we're looking at teeth, understanding between keeping teeth and removing teeth and placing in implants, we have to take into consideration the patient's concerns. We have a fiduciary responsibility to them, which means that we have to put their concerns above our own, their interests above our own. It's very important to try and save teeth when we can. That's why we have now LAPIP in the picture, and before we place implants, we can now save them, especially if they have gum disease, and because implants have their problems, and we're going to get into that right now. So we have to distinguish, do we save teeth or do we take them out? Do we place implants or not? But once we have placed implants, let's look at online. I've seen some things that are disappointing, and disappointing to me in the sense that I'm concerned that some unscrupulous people have taken advantage of our patients and placed implants when saving their teeth would have been the appropriate recommendation. Let's take, for example, this video, and you can find it on YouTube. It's a video regarding the all-on-4 system case. This was on All-on Forum, and it's a case of 4 implants holding up the lower denture. And you can see here, let's stop it. This patient had a couple cavities, a couple broken teeth over here. He had broken off the porcelain on his front 2 PFMs. So we could have replaced these 2 with 2 new porcelain crowns, a crown here, and a crown here, and maybe 2 root canals. So that's 3, 4, 5 crowns, a LAPIP. The cost of that would be about, let's see, 1, 2, 5, about $12,000 to $15,000. The treatment, I've asked different dentists on what would the cost would be to remove all these teeth and to put in all-on-4 on the top and all-on-4 on the bottom. I've had kind of different numbers between for all-on-4 on the top and all-on-4 on the bottom, 30 at arch, so $60,000 instead of 12 to 15. And again, the implants are not as good as natural teeth, and I'm going to show you the literature that supports that position. So let's look at what they did. That's the before x-ray. Again, you can see a cavity here, a broken tooth, the 2 crowns that need to be replaced because of the porcelain breaking off. This dentist decided to remove all the teeth and put in 5 implants on the bottom and a denture on the top. Notice the bone support around these teeth hasn't even hit the furcation. the immediate post-op CBCT of this case. 4 screws. They screwed the patient with an upper denture and a fixed denture on the bottom. I was kicked off of this forum for saying that I didn't think this was appropriate treatment. And you could watch this online. Go to YouTube, click on All on 4 Dental Implants Downey, and you can see the whole video there. We have a lot of patients who have advanced periodontal disease. If you look at the literature, 50% of Americans have moderate to severe periodontitis. This case, we attempted to save it with LAPIP, but LAPIP is not perfect either. When there's no bone around the roots, you could try anything and nothing's going to work. The challenge is to get up in those furcations is impossible to clean out these areas. If you look at the tissue doesn't look too bad, but it started getting a periodontal abscess. So we did have to lose and remove this tooth. But the challenge now to replace it with implants, this patient is not a good candidate. The literature is very clear that periodontitis is a risk factor for dental implant loss or peri-implantitis. And you could look up these articles online. So now we have patients who have had periodontitis previously and they get implants. And what happens is they get peri-implantitis now. And so we're seeing quite a few of these implants becoming infected. And now we have a procedure that could reverse that. So how big is the problem? 80% of patients, and 50% of those implants will develop peri-implantitis or peri-implant mucositis. 28% to 56% of the patients and 12 to 40% of those implants will develop peri-implantitis. I guess so. This study, Zittman, has this divided into peri-implantitis and peri-implant mucositis. So it's quite common, this mucositis and peri-implantitis. It's a major problem. Costa, 2012. In the US, 400,000 cases of peri-implantitis. In Sweden and Switzerland and Italy, 40% of implants have peri-implantitis. About 1 million dental implants are removed worldwide annually. The challenge is that traditional treatments are failing. So there's no clear choice at this point, and there are high failure rates with conventional treatment. And you could look it up, peri-implantitis, British Journal of Oral Maxillofacial Surgery, November 20th, 2011.
What is LAPIP? LAPIP is an acronym for Laser-Assisted Peri-Implantitis Procedure. LAPIP is an alternative to traditional flap and osseous surgery for implants. The procedure is for people who have gum disease around dental implants. For an accurate diagnosis, visit your dentist. They have to take a full series of x-rays and evaluate the bone support around your implants. Then, and this is critically important, they need to have your gums evaluated, and 6 measurements per implant need to be made with a periodontal probe. The instrument is placed between your gum and your dental implant, and a measurement is taken in millimeters. Healthy numbers are 1, 2, and 3 millimeters. Anything greater than 3 and bleeding, then this is a sign of gum disease. If your dentist does not take these measurements, it is dentist. Gum disease is responsible for being the #1 cause of implant loss. The laser procedure, unlike traditional gum surgery, requires no cutting or amputating of the gums. Since the tissue is not amputated nor peeled off the bone, no sutures are needed. Patients who have gone through treatment usually say the day after and a week after that they have about a 2 on a pain scale of 1 to 10. To see several video reviews, visit lasergumdentist.com and click on the Testimonial tab. LAPIP is done with the Peri-implantitis laser. Don't be fooled by anyone that uses a different laser and claims to do LAPIP. Buyer beware. To see some remarkable cases, visit our website and click on the before and after page. We have also included the cost to have the procedure done. Visit us at lasergumdentist.com.
So I created that video. You can find it on YouTube. Just type in LAPIP. I made it for about $30, and when you come through training with Millennium, if I'm your instructor, I'll teach you how to do one of those for under $30. You can find published literature on the LAPIP protocol. This is the actual article. Some very interesting cases. The conclusions: the rate of infection progression is exponential. In these cases, LAPIP intervention resulted in an immediate and complete recovery. Rate of recovery about 30 millimeters squared per year. Here's a case. These are the cases that were in that article. Dr. George had this x-ray. Patient come in, did LAPIP 7 months later. It's nice to see the bone fill in. We have Dr. Finkenbeiner. Count the threads. 1, 2, 3, 4, 5.5. Oh, nice to see that. Dr. Norian. Old calcitech. Can you imagine if you had to take this out? What about the bone around this one? You'd probably end up losing that tooth too. But not anymore. Here's a Dr. Salama of Dental XP of Salama, Garber, and Goldstein. And he submitted this radiograph 7 months later. Again, count the thread right there. Look at the thread. Nice result. Here's Dr. Lamas. Again, count the threads. What is that? The one on the bottom? The first one? 1, 2 here. Look at it here. 10 months. 1, 2 here. Oh. Nice to see that. The nice thing about this is that no biologics were placed in here. No scalpels, no sutures. Since no biologics are placed in here, the risk of, and there's documented literature that shows that there's some concerns when you put in foreign bodies into people. Here's Dr. Thien. Again, count the threads. 1, 2, 3, 1, 2, 3, 4, 5, 6, 7, 8.5. 1, 2, 3, 4, 5.5. But look at the distal here. 1, 2. 1, 2, 3, 4. You know. Nice to see that happening without putting in biologics and without the risks of biologics, without the pain of cutting somebody open, without the pain of sewing them back together. Again, Dr. Fourier at 6 months. She has quite a few cases, and she presented at the Millennium Study Club. I'm looking forward. I think she's going to be publishing. She has so many cases of LAPIPs that I know she'll be publishing soon. Dr. Vassos, Again, you can see the bone supporter in here, before and after at 6 months. We have Dr. Tom McCauley out of Florida. Tom McCauley is an interesting person in the laser literature. He's the Cobb-Macaulay paper that gets paraded around saying that lasers burn roots. Well, you should ask him about that paper and what he thinks of that paper. Very interesting. Chris Blodgett up in Washington, a general dentist. This is the progression of the peri-implantitis. At 2 years, the LAPIP was done at this date, and it's nice to see it filling back in over 36 months. This is a very interesting case. This is Dr. Lehrman's case. He talks about this case as this is Mr. Napolitano came into the office. This is actually Dino, if you've seen him online, his uncle. And his uncle came with this in his pocket, I believe. It was outside the mouth, basically. And he had a wedding that night, or that weekend, and he said, look, I don't care what you do, but you put that tooth back in, you glue it together, do whatever you have to do. I got to show up to that wedding with a tooth in my mouth. And he said, okay, I'm going to put it in for this weekend. And then you come back next week, and then I'll take it out and we'll graft this area and we'll put in a new implant. Well, Mr. Napolitano chose not to come back for 7 months. And they took a new x-ray and they said, well, you know, why don't we wait around and see what happens? And at 18 months, wow. And these images with the green around it, the computer does that. And the computer determines how much bone change in density happens in it. And this is the graph of the computer telling us between the Blodgett and the Lehrman case, out 1 year, you get this much density, and out a year and a half for that much improvement in the cross-sectional area of the lesion millimeter square of how much density of bone gets filled in over time. The Blodgett case at 1.5 years and the Lehrman case at 3 years. So over time, it gets better. The foundation of our practice are our patients. Some of our patients, I told one patient it'd be a good idea to go to my oral surgeon and have an implant placed. Well, this patient drives up and down the freeway, and if you've ever been to Los Angeles, you'll see these billboards for $399.
Do you really need implants? When you really need implants? Why work on this when you really need to work on this? At Whittier Dental, we understand your...
Hi, this is a case of peri-implantitis. This patient is basically has an infection around this dental implant. He had this implant placed about 6 months ago at a surgeon's office that basically has billboards all around our city that promote about implants for $399. The patient felt something and didn't feel like it was feeling right. So he came in and asked me to take a look at it. And as you can see, he has about 12 millimeter pockets and suppuration. The surgeon told him to just basically rinse with oxidine and he'll be fine. The other recommendation was once it became loose, then he could come back and they would reevaluate the situation. So apparently the standard of care is wait till teeth or if these implants become loose. We prefer to do treatment prior to the implant failing completely. And we've chosen to do a LAPIP process, which is laser-assisted peri-implantitis. So this is the before, a lot of bleeding, 12mm pockets, separation. The patient did feel, this is after, 6 months after, and you can see about a 4mm probing depth here around this, about a 3 or 4 millimeters around that. And you can see the tissue blanching. So that's showing us that, yes, I'm putting a little pressure around there, making sure I get an accurate reading. We didn't get any suppuration, but there on the distal, there was a slight amount of bleeding. So I'm considering maybe down the road we might want to touch it up or retreat again. This is the actual LAPIP procedure. The LAPIP procedure is a patented protocol developed by Millennium Dental Technologies, utilizing their ND-YAG, the Peri-Laser MVP7. I'm going to stop that there. This video is on YouTube, and you could watch it there. You could watch what happened to the tooth next to it also, and the actual procedure being done. Again, the foundation of our practice is our patients. The foundation of their teeth and implants is the periodontal ligament and the gums that support the teeth and implants. This is one of my cases. Again, count the threads. I have more of a bite wing type of x-ray here where you could actually see the threads a little better. You can see the amount of bone loss running almost, they cup out like this, and you get that exponential bone loss. And this is after, about 6 months after. Again, you can see the bone fill after the LAPIP process.
More and more patients that are being told by their general dentist, you're losing bone around your implant.
That is
so
true,
what are
yes.
the therapies? What do you do?
This was one of the most frustrating areas of periodontics and implant dentistry because nobody had any good ideas. Most of the therapies were recommending simply take the implant out and replace it. Well, considering what it takes to put an implant in, most patients were not thrilled with that option. One of the things that really compelled me to look seriously at going into the laser periodontics area was implant-associated bone loss. With the laser, we do an approach that's very similar to how we approach natural teeth, and it's very easy, it's very economical for patients. It's a beautiful first step because we can resolve the majority of patients' problems with this step alone.
So if the implants are starting to get loose, maybe?
Not loose.
Infected? Or what?
The implants will stay solid right up until they totally fail and come out.
So how do they know that there's even a problem?
Many patients won't.
I mean, it just shows up on an x-ray that the bone's
It shows up
away?
on the x-ray, or their hygienist might have noticed that there might have been a little drainage around the implant. And what we know now is that if there's any changes in the soft tissue like that around the implant, it needs to be jumped on right away because we don't want to wait for x-ray bone loss to show up. Radiographic bone loss, by then it's already advancing.
So you zap it with a laser.
We zap it with the laser.
And the bone what?
The bone will often regrow.
Interesting. So you're seeing good results with
Good
this.
results. And what I like about it is that it's very economical, it's very easy for patients to go through, and it will resolve the majority of the problems for patients.
So you said good results. Are they great results? Or the challenge is by the time they get to you, it's pretty far gone?
If they're too far gone, then it gets difficult.
So if you could get these people early.
Early, yes.
It's great.
Then it's great. Then things work out really well.
One of the issues regarding peri-implantitis that comes up quite a bit is cement sepsis. The cases I've seen, I have a different opinion. I think it's periodontitis that's affecting these implants. Because if you look at this case, there was no cement. So if there wasn't any cement, how could it get peri-implantitis from the cement? Again, almost 8mm pocket there, separating. This case is now out, I'm going to say 8 years, and it has not recurred. There's the x-ray. I do place mini implants. Even though they're mini implants, they are 3.0 by at least 12. Again, the foundation of all our dentistry is the periodontal health. This was an interesting study from the Japanese. They found out that we humans have the same bacteria as our pets. They genetically tested the bacteria in the dog and in the owner, and they found out that it was the same bacteria. Here's another case. It is posted on YouTube. You can see the before, after, and during the procedure. If you type in LAPIP on YouTube, you could watch it. Again, there was no cement sepsis here because these were healing screws. He was intended to be an all-on-4, but ended up by none-on-3. The problem, though, is they never handled or appropriately handled the periodontal issue and the implants. In my opinion, that's why it caused the peri-implantitis. So he had a LANAP on the bottom and a LAPIP on the top. That's the 1 week after. You could see the scab, we call it a wet scab, around these implants. Some people online on Facebook have mentioned that these abutment screws got dinged. Yes, they did, but they're abutment screws. You're going to take them off anyway. So what does it matter? And you can watch the actual video on YouTube of the procedure being done. Let's see, it's taken. You can watch it being done again. The pre-periodontal charting. That's so you can also watch this video on Facebook. Somebody actually downloaded this video. So you can go online on Facebook, and the place where it's been downloaded is UK Dental Laser User Group. The fellow who downloaded it is a Mark Cronshaw, and he chose not to show the post-op. This video does have pre-op, the operative, and the post-op, but he just went on and said I put too much energy. I suggested use. Here's the actual quote: "I do not have an NDI. The suggested use is for the management of peri-implantitis. However, the amount of laser tissue interaction with this patient's tissues as well as the implant is one that concerns me." Comments anyone? Now, why would it concern him, and why wouldn't he show the after? Well, obviously he's not going to show the after because it's clear that we reverse the condition. So he has his bias. I think he works for one of these laser companies. So people start commenting, and too much energy, only erbium lasers should be used in peri-implantitis. Other people wrote in RIP, rest in peace. We did have somebody who had some intelligent comment, and Dr. Robert Miller asked, was this used in continuous or pulse mode? What were the settings? So those are intelligent questions. We also had Larry Nurin say, "Hi Mark, I've seen this video before and I included in my lectures is what not to do." Now Larry, do you show the after? Come on Larry, show him the after, and then you could comment about what not to do. The NDI produces more than 1200 degrees of heat in the pocket and you can burn the implant, as seen in the cap defects created. Yes, I hit the healing cap, and so what? Look at the result. Look at the after. That's what counts, not whether if the implant got dinged or heated up or not. And it did not exfoliate. He's saying, and ultimately cause exfoliation of the implant. And you wouldn't want to try this on your spouse? Yes. Not only would I do it on my spouse, I'd be doing it on my best friend. I'd be doing it on my mother, my father, anybody who had peri-implantitis. Look at this. LAPIP was performed after 5 months. New measurements taken. Look at this, Larry. Why don't you show this at your lectures instead of you and Mark showing the negative? Why don't you show this, Larry and Mark? That's what you have to show. Not just come in and bash me and rip off my video. Come on, Mark. Show the original. You know why you won't show the original? Because it has a link to right there. It shows the after. And you can't handle that, Mark. Neither can you, Larry. How about Don Caluzzi? He comes on and he starts saying you should never use an Nd:YAG around an implant. Come on, just because there's some literature showing that, yes, it might heat up or something. But what about all these cases? What about all these cases, Don? Look at the cases over and over again. We're getting great results, Don. So you might want to check it out again and reconsider what the literature is telling you, because everybody's getting some great results. Caluzzi, everybody's. So, you know, reevaluate this situation. Look at the cases I posted here. Look at the befores. Look at the afters. I mean, it's clear that the Nd:YAG is a great tool around implants. And no, these implants don't slough off and whatever you guys want to make silly comments about. But grow up and look at what everyone's doing. So some advantages to LAPIP is that there are no scalpels used, no sutures are used, no biologics are needed or used. There's minimal discomfort to the patient. The one that's really interesting is the biologic issue. I'd suggest you Google Alistair Cook's bones and see why our biologics have been removed from the market at least twice now. And how about the Spine magazine coming in and showing that Infuse has all sorts of Frankensteining problems with it. You can get sterile and cancer. You don't need to use those biologics. How about prions? Creutzfeldt-Jakob syndrome. It's in our literature that you can get these problems. So stop using biologics. Start using the own patient's healing response. How about the J Clinical Perio? Implants cost 5 times as much money as teeth to maintain. They're putting the main principal author with a little video on the side, like what I'm doing right now, and he's explaining how he got these numbers. Very interesting way of presenting these. If you read the article, it'll probably put you to sleep. But watching the guy who did the presentation, it's very interesting.
Gary M. Schwartz, DDS MSD. I practice in my primary office in McAllen, Texas, secondary satellite offices in Harlingen and Brownsville, Texas. And so now, towards the end of my career, Millennium Dental comes along with this technological discovery that they call the Peri-Laser MVP7. It's an Nd:YAG laser that, through the physics that they have done to design just the right energy to impart this photon with just what it needs to go in and selectively wipe out the bad bugs, selectively remove those tissue components that are not helpful around a tooth that's being rejected or an implant that's being rejected, and then developing the rest of the protocol that really focuses on occlusion and eliminating those problems. And the result blows my mind. Bone growing back around teeth? Are you kidding me? Bone growing back around implants? Are you kidding me? much less getting rid of the infection. It really happens. It's shocking. It's incredible. I can't believe it. Now I've really got a package. I've got Branamark's titanium creation, and now through these guys, the ability to get the sick ones well. What a package that is. And these folks, I believe, time will show that their shoulders and this technology that they've developed are as tall as Branamark's himself.
So let's talk about implants and failure. Why do implants fail to integrate? PPP, piss poor protoplasm. Some people just are sick and they don't heal. You can't place implants in people who don't heal because the bone needs to heal around these implants. The bone quantity, not wide enough. It's been a long time since the teeth been out. The quality of the bone, is it hard or is it like Mish talks about the different types of bone being different types of wood, maple or balsa wood or styrofoam. Smokers just don't do well. They don't heal well, and they lose their implants more commonly than people who don't smoke. Occlusal stress, obviously, if you overstress an implant, you're going to just push it right out. Early loading and endodontic infections near the implant itself. Again, our number 22, titanium. Thank you for sponsoring this program. Let's look at a case. Here's a case that, we decided that implants were in his best interest, so we removed those teeth, placed an implant, did a cantilever, maybe it was under-designed, and found out that there was a screw broke off inside the implant. We got it out, fortunately, just by reversing it out with an Explorer. Only thing was that it broke again, and the next time we weren't able to get it out, and we had to explant the whole thing. Had to re-implant two, this time designing it properly. Looks like I'm on top of that root, but if you look at it from a different angle, a little bit better there. Problems with implants. Have you ever had an implant flower out? Now what do? You got to explant it. You got to take it all out. So implants have their problems. This is a case that came to me, and he had advanced periodontal disease around that implant, and it was basically, we couldn't even save it with LAPIP. It was so advanced, there was no bone left, so we decided to remove it. And the challenge is we were trying to figure out what implant that was, and it was just easier to cut it out. I can't imagine, and I don't understand why dentistry allows so many different implant abutment types of screws. Just Branamark itself has had 4 different implant abutment screws, each with a different type of hex. And shouldn't we standardize the type of screws that are put in people's heads? It's just incredible, all these different implant companies having these different implant sizes and shapes and abutment screws. How about micro movement? Go to YouTube and type in micro movement, and you'll see this pop up. And this fellow has done some really interesting things with his implant abutment interfaces and the
problem with our soft tissue. And
the micro movement and the gaps between all these different implants, and how just junk gets into these implants,
what is the reason for
and that micro gap,
and why we have some
very interesting presentation on YouTube regarding the micro gap. on these implants, I'm going to recommend you take a moment and take a look. I'm going to suggest you go to YouTube and click or search for FESS, F-E-S-S, and you could look for dental implants and FESS, or extraction and FESS. These are our ENT colleagues that are putting kind of like a intraoral camera into the sinuses and going into the maxillary sinus. You can see there's an implant stuffed up into the sinus. I know if I were doing sinus lifts, I'd love to have one of these FESS units. It's just basically a camera that you drop through the patient's nose. They drop it through the nose, and it's amazing what they do with these instruments. They're very aggressive with all the tissues inside the sinus. We're worried about tearing the Schneiderian membrane. Well, if you watch some of these ENTs go at the sinus, you'd be amazed at how aggressive they are with their procedures, just basically hacking away at all the tissues in there. It's really interesting. Well, I mean, from my perspective, that we don't get into the sinus, other than going into the sinus lifts, but being able to see it from this perspective, from going in through the nose, and then seeing these implants that are all with peri-implantitis from the sinus perspective, it's interesting to watch. This next video is a video from a fellow who has about 100 of these videos. He's using a surgical microscope, and there's implant after implant after implant of these broken screws, and he's going in there with his microscope. The guy has the patience of a saint to go in there, go on YouTube, type in broken implant abutment screw, and he'll show up. You could see him go down into the implant. He'll place tartar and stain remover down there for about 5 minutes. Then he'll go in with his little sharp instruments and trying to back out these abutments that have broken in the implant fixture. So again, implants have all these problems that we wouldn't have to deal with if we would just choose to help our patients keep their teeth. These implants have a lot of problems. Imagine trying to get in there and fish out these little itty-bitty implant abutment screws. I've done it, and it's not much fun. This guy is an incredible pro at doing it, running in there with the surgical microscope and looking at these little itty-bitty screws and backing them out. I suggest go on YouTube, watch his work. Great stuff. Hope you never have to do any one of these. Sure would be a miserable day. Well, you could always refer to him, but I think he's in the Michigan or something. You can look him up. You'll send your patients there. Hey, so I look forward to seeing you online. Again, you'll find LAPIP on YouTube. Make sure you comment about this on this video, and I'll see you soon. Good day.